Hey guys, welcome. So we are approaching the second to last lecture. We're going to be learning about fluid and electrolytes and complete blood counts. Oh, what is that? Well, there's a lot to learn, so let's get to it. So for this section, I do want you guys to kind of go back and look up what you learned probably for a lot of you a long time ago in chemistry. Just basic information such as cations and anions and things like that, because we are going to be talking a lot about a lot of things that we did learn in chemistry. So guys, remember that us adult humans are primarily made of water. I think we've learned that many times in our life. So we have to drink so much of it, right? So we have it is a delicate balance of fluid and electrolytes. And then later in your preceding blocks, you'll learn about acid-base balances that still have to do a lot with electrolytes and fluid balance. But here we're going to learn the basics and how any disruption can cause a lot of chaos. And a lot of fluid and electrolyte imbalances can have severe effects on a person. So let's look at body fluids in general. What does it do? Why do we need it? So the primary body fluid is water. So we are, 50 to 60% water. How does the water in our body function? Well, it can transport nutrients, can transport hormones, enzymes, blood, platelets. It'll facilitate cellular metabolism and proper cellular chemical functioning. Water helps us maintain our temperature. It facilitates digestion and acts as a tissue lubricant. That's why when somebody is severely constipated, we tell them to drink a lot of water, fluids, right? Because we know that our body needs that moisture so that it makes our feces soft and easy to get rid of. That is just kind of basic of what water in our body does. Know that the total body water or fluids in our body are 50 to 60% of our weight for a healthy person. And you will see that it can change as we get older. So the body fluid usually is located in two fluid compartments. One of them is the intracellular fluid and the other one is the extracellular fluid. And it is basically a base of where it is located. So intracellular fluid is the fluid within cells. And it consists about 70% of the total body of water or 40% of the adult's weight. The extracellular fluid is outside of the cell. So just know, intracellular, inside of the cell, extracellular, outside of the cell. And it accounts about 30% of the water in our body, or about 20% of the weight that we carry. So as you can see in these diagrams and pictures, so the one here is showing you where everything is pertaining to fluid in our body. So know that extracellular fluid has actual kind of two areas within the extracellular fluid. So that is called intravascular and interstitial compartments. There is a third, usually smaller compartment called transcellular fluid, but it's very minor. And intravascular fluid is known as plasma, and it is a component of blood, and it is found within the vascular system. So think veins and arteries. Interstitial fluid is fluid that surrounds tissue cells and includes limbs. So that's it's around the cell but not inside of the cell, and it could be in so it's kind of like the in-between. It's like a cushion almost. So I want you to think of the intracellular fluid in this manner. So think of a box. I'm going to draw a very horrible box here. It's really hard to draw with a mouse. So this here is your intracellular fluid. And it accounts to about 25 liters in the body, or 40% of body weight. That's pretty significant, right? Now, let's just change this for color. We have extracellular fluid, and we learned that with extracellular fluid there is 2 separate compartments. So we got the interstitial fluid, so I'm not even going to try to write all of that, but interstitial fluid. That's really horrible. Dot, dot, dot. And that accounts to about 12 liters. And 80% of the extracellular fluid. 80% ECF. It's really hard to talk and do this at the same time. Okay. Now, so now we're missing about 20% of the extracellular fluid, and that 20%, or about 3 liters roughly, is plasma. Plasma. Kind of wish I had an Apple Pencil now. Three liters and 20%. So our fluid system is a lot. 25 liters plus 12 liters plus 3 liters. So that is, so altogether, 40 liters. That's a lot. That accounts for 60% of our weight. So this is for a healthy, normal adult, 60% of their body weight. So as you can see in the figures here, how much and where each fluid space is. And we do have a lot of body fluid, so it's a big component of a healthy human body. So what is fluid balance? So fluid balance is, fluid balance is how we as humans maintain that balance with water in and out of our body. So you can see in figure 40-2 the approximate fluid intake and fluid output and where things come out. We have to think about insensible loss and sensible loss. So and you guys got to remember this from lab where we learned intake and output. There are things there are outputs we are able to measure, and then there are outputs we kind of estimate because we don't have like a true way of measuring, fluid, where anytime we breathe and talk, we're exhaling fluid from our lungs. Sweating, our skin sweats, and we can have quite a bit of sweat. We know some people are very sweaty pretty easily, so knowing that there has to be a balance is very important, especially when taking care of patients when they're ill, because we want to make sure that those fluid balances are correct. So fluid balance is maintaining that almost equal intake and output. And our body does much of the work to make sure we have a fluid and electrolyte balance. So the way that we intake fluid is actually dictated by the thirst mechanism, and thirst mechanism is comes from the hypothalamus in our brain, and when it is stimulated, it usually means there's a deprivation or water loss or decrease in blood volume. We get water, so from many different ways. We can get water from food, actually drinking water, and metabolic oxidation. And we know that much of how much water we drink is dependent on the person's diet. We know that a lot of fruits and vegetables contain high amounts of water, as opposed to like pasta and things like that do not. So, knowing where people get water or fluid to ingest is very important when you're teaching somebody who is going through a fluid imbalance. Maybe they're severely dehydrated, or maybe they're fluid overload. So it just depends on what's going on, but we need to be able to tell people where they can obtain water and fluids. In general, we want somebody to consume about 2,600 a day, right? Or we want somebody to intake a lot of fluids per day, and we want to see where it's coming from. And then we know that we have an average of output of 2,600 to 2,900, depending on the person and how much they're intaking. And remember, we have a lot of GI loss in fluid that isn't accounted for, because if you're a normal, healthy adult and having regular bowel movements, your body is absorbing the water from stool and makes it a little more formed. And we know that when people are dehydrated, your bowels are working extra and it kind of constipates you. So we want people to intake quite a large amount of fluid, but we have to also remember that fluid just doesn't come from water, it comes from other things. But we recommend an average of 25 to 2,600 mLs per day. We might not see an exact intake and output. It will, we might not see an almost even intake and output, and sometimes it might take a little longer for people to even out from what they're ingesting to what they're putting out. So don't be extra alarmed if it happens. It has to be a completely significant number for it to be alarming. So say you're drinking 2,500 mLs of water, but you only peed 200. Well, that's an issue. But if you're drinking 2,500 mLs of water and you're peeing 2,000 of it, that is probably okay, because we know that our body also gets rid of fluids in different ways. So fluid balance is important because we know that any deviation in fluid balance, whether somebody is dehydrated or has fluid overload, can cause some troubles. It can cause illnesses. It can be caused by an illness. So taking care of that and making sure that we are able to treat it is what's important in nursing with any fluid imbalance. So what are electrolytes? And we remember these from chemistry, right? Chemistry was not my favorite, so. But electrolytes are substances capable of breaking into particles. What are those particles called? Ions. And what are ions? Well, ions are small or atoms or molecules that carry some sort of electrical charge. Ions that have positive charges are called cations, and then those ions that have negative charges are called anions. So we know that in our body we have different kinds of cations and anions, and we know that those are electrolytes. In our body, the cations present are sodium, potassium, calcium, hydrogen, and magnesium. And then anions that we have in our body are chloride, bicarbonate, and phosphate. And these electrolytes can vary within various compartments of our body fluid, and they will differ significantly. We know that electrolytes in our body have a pretty small margin of change where things can go wrong or that can have an effect on our body. So as you can see in the slide, we have this chart, and you can find that in the book as well, but it shows how much of each either anion or cation is located in our fluid compartments. So as we can see, sodium is actually pretty big in our plasma interstitial fluid and really small in the cellular fluid, so inside the cell. As opposed to potassium, look at how much potassium is inside the cell compared to it outside of the cell. And then calcium, it's pretty low everywhere, right? I mean, there's still, more calcium in plasma and more calcium in cellular fluid than there is in the interstitial fluid. So this is why it's important to know what is, extracellular fluid, intracellular fluid, and then within, I think I forgot extracellular fluid in there. So, and within the extracellular fluid, what's there. So sodium, potassium, calcium, magnesium, bicarbonate, chloride, phosphate, and sulfate. And we know that small changes in these electrolytes can have a varying significance on patients. Remember that electrolytes are measured in terms of a chemical combining power. We use electrolyte measurement as milliequivalents, or MEQ, as the unit of measurement for the chemical activity of the electrolyte. We know that the total cations in the body are normally equal to total anions in the body, and that maintains a balance. So in healthy people, we know the milliequivalents per liter for electrolytes in the body, and they vary within a relatively narrow range. So when electrolytes are not in balance, the person who has that imbalance can cause health alterations. They will have issues. So how does our body regulate or keep homeostasis of fluid and electrolyte balance? There are many mechanisms that our body uses of many organs and things that we do that we don't know what's going on, but it is, so that we keep and maintain a fluid and electrolyte balance. So think about chemistry, right? We had solvents and we had solutes. You guys remember those? So solutes are the substances that can be dissolved in a solution, and the solvents are the liquids that hold the substance in the solution. So that's just, that very basic chemistry. So, when we're dissolving something like salt or sugar, like remember that? Sometimes it's really easy to dissolve salt, sometimes it's really hard to do it. But we know that when we add salt to water, it changes the way that water works. We know that adding salt to water changes the boiling point. So our body is doing a lot of that. It's kind of like the under wraps of everything. So how do the organs and body systems provide homeostasis? So each organ, or not each organ, but there are several organs such as the kidneys, our lungs, things like that, that have a specific function for fluid balance. So looking at in the textbook table 40-2, we see that kidneys regulate extracellular fluid. It regulates electrolyte levels in our body. It gets rid of metabolic waste or toxic substances. And we know that the kidneys filter 180 liters of plasma daily. That is a lot of work for kidneys. This is why and some of you that have gone to clinicals and things like that and have seen people with dialysis, we know that dialysis is doing the function of the kidneys outside of the body. So if your kidneys are not working, then you're not getting rid of toxic waste. You are not regulating your extracellular fluid. So problems with the kidneys will cause fluid and electrolyte imbalances. Our hearts and blood vessels, well, the heart and blood vessels, the heart pumps everything everywhere, right? The blood, which is part of our cell, or part of our fluid components in our body. And our heart also regulates by reacting to hypovolemia or fluid retention, things like that. Other ways our body regulates fluid and electrolyte balance is through the process of osmosis. Knowing osmolarity, knowing what an isotonic solution is, what a hypertonic solution is, and what a hypotonic solution is. All of these things will regulate fluid and electrolyte. We also have to know what diffusion is, active transport, and capillary filtration. We know diffusion is a tendency of a solute to move freely through a solvent, so it can be kind of like everywhere, as opposed to active transport requires a source of energy. You guys remember ATP? Well, that ATP is required to have active transport because it needs that energy. So, and then capillary filtration. So we know capillary filtration is the result of blood pushing against the wall of the capillaries. We know capillary filtration occurs in things such as the lungs, in the alveoli, where it pushes all that oxygenated blood against the capillary walls so that it transports oxygen, or to get oxygen. So it just depends. So we know in the body we have some major electrolytes, and they have functions and how they're regulated and sources and losses of those. So if you look at chart 40-1, the major electrolytes, you can see sodium. That is the main electrolyte in our body. We know the normal concentration and the functions of it. So one of them is a role in muscle contraction. Where do we get sodium? Well, we know we get sodium from our diet. Where does it go away? We sweat it out. Our gastrointestinal tract, our kidneys are certain places that we lose sodium. Then we know that sodium is regulated in the kidneys. It's regulated by that renin-angiotensin system, and then it can be transported in and out of the cell by the sodium-potassium pump. So go back to chemistry, guys. That sodium-potassium pump has a lot of meaning in our body. It literally is how our cells survive. So the next major electrolyte value is potassium. It's a major cation. It has so many functions, lots of sources and ways it's lost, and then regulation. So if you remember that chart from before, where is our sodium? Which is it in the intracellular or extracellular compartments, or how does it work in both? We know that potassium is a regulator of enzymes and has so many roles in our body, including muscle, nerve impulses, regulation of acid and base balances, electrical impulses. We know we can get it with a well-balanced diet. Lots of bananas, right? There's also lots of fruits that have potassium in them. And then the way it is excreted is through our kidneys, our stool, sweat, and vomit. It is regulated by aldosterone, or our adrenal glands. Our kidneys eliminated, and then other regulations are via the shifts between the intracellular and the extracellular fluid. Calcium is the most abundant electrolyte in the body, and we have our normal levels, and you want to know what's the role in our body, how we get it, and how it excretes our body, and then also what regulates it. So calcium has a huge role in coagulation, in actually regulating our muscles and our muscle contraction. And the biggest thing is calcium is what our bones and teeth are made of. We need it. We need it in our body. How do we get calcium in our body? Well, so we know that it's absorbed from food, and we use it in the presence of gastric acidity, and through vitamin D. We can get calcium through milk or dairy products, beans, leafy vegetables, and it's mainly excreted by the gastrointestinal tract, and some kidney functions do excrete it. We know that our thyroid/parathyroid hormones regulate it. So I know with people who have thyroidectomies or cancer in thyroid, one of the biggest concerns is their calcium, that they're going to lose it, that they're not going to produce enough of it. So magnesium is the second most abundant electrolyte in intracellular fluid. So magnesium has a huge role in carbohydrate metabolism, neuromuscular function, cardiovascular system, and it actually produces a side effect of vasodilation. So magnesium has entered our body via the GI tract. We want to eat it, and it's high in green leafy vegetables, nuts, whole grains, dried pastas, and lost in urine, kind of when we use loop diuretics. It is eliminated or excreted by the kidneys and regulated by our parathyroid hormone. Chloride, it's the major extracellular fluid anion. It is a major component in the interstitial and lymph fluids, our gastric and pancreatic juices, acts with sodium to maintain the osmotic pressure, and combines with hydrogen ions to produce hydrochloric acid. That's in our body, guys. Remember when we were afraid to touch hydrochloric acid in chemistry? We kind of produce it sometimes. The way we get chloride is through our diet. So we want foods high in sodium, processed foods. We don't want them, but that's where they're found. So almost all chloride in diet comes from salt, because the salt we eat is sodium chloride, like the stuff that we put on our food. And sodium chloride is also normal saline, things like that. So sodium, because chloride and sodium are usually kind of together, it is regulated through our aldosterone and also with our kidneys. Bicarbonate regulates our acid balance. I know you guys are not learning about bicarbonate, but that is also one of our major electrolytes. It's also known as a chemical buffer. Phosphate is another one. It has much to do with our acid-base and electrolyte balance. We find phosphate in all animal products, so meat, poultry, dairy. It's added into ready-to-go cereals. It's eliminated by the kidneys. Regulated and activated by vitamin D. This is why a lot of people need vitamin D, because we need this regulation to continue to work, because otherwise we're going to be imbalanced. All right, so let's just get going with these fluid and electrolyte disturbances of balance. There are several kinds. Most of them are based on the type of electrolyte. But we know, so we have fluid volume deficit, which means what it means. It's not enough fluid volume in our body. Remember what the percentage of our body weight fluid is, and if it is too low, it is going to cause a lot of issues. With fluid volume deficit, that'll be like dehydration, right? It could be loss of both water and solutes in the same proportion from the extracellular space. So when it's from the extracellular space, it is known as hypovolemia. And that will force the interstitial fluids in the intravascular space to compensate for that fluid loss. And as that space is depleted, the fluid becomes hypertonic And cellular fluid is then drawn into the interstitial space, leaving cells without adequate fluid. So that is a fluid volume deficit that can result from loss of bloody fluids, such as significant bleeding, diarrhea, lots of vomiting. So a true fluid volume deficit can be, or a life-threatening, let me rephrase that, fluid volume deficit would be a 15% of weight loss in our fluid deficiency. So remember, we have 60% of our body fluid is our weight, and then if we lose 15% of that weight from fluid loss, it can be life-threatening. A 5% loss is significant, and then an 8% loss can be severe. So, but 15% loss or more, it is life-threatening. Something can happen in fluid volume deficit called a third space fluid shift. So we learned about the different compartments of fluid, and then that minor transcellular compartment that's like found in the pleural space, in the peritoneal area, in the pericardial area, joints, and the bowel. Sometimes this third spacing will cause fluid volume deficit because it causes fluid to shift from so it causes an excess accumulation of fluid in the interstitial space, or in that transcellular compartment. The fluid moves out of the intravascular spaces, so the plasma, to those spaces, and once it is in there, it is really hard for it to move back. It doesn't really exchange as easily like it does in our vessels. With third space fluid shift, a deficit in extracellular fluid volume occurs, because although the fluid is not gone, it is not in the place where it needs to be to continue to keep a balance. So that fluid is trapped, and it's really hard to reverse it, to go back into its normal compartment of fluid. A lot of the time, these type of third spacing can happen in a specific kind of renal dysfunctions, changes in permeability, and a third space shift may occur as a result of a severe burn or a bowel obstruction, pancreatitis, liver cirrhosis. So decreased body weight does not occur because the fluid itself is not lost, it's just in a different space in the body. All right, and then the opposite of fluid volume deficit is a fluid volume excess. So fluid volume excess, or FVE, is an overload of fluids. We know many things that can cause that. So a lot of the common causes are malfunctions of the kidney, the inability to excrete excess, the failure of the heart. So there's accumulation of fluid in the lungs or the dependent parts. We know that, and a fluid volume excess will almost certainly cause weight gain. So the accumulation of that fluid can cause what we call edema. We've learned about edema, edema in the ankles. So edema is that fluid accumulating, but it has nowhere to go. It's hard for it to be excreted, so it just continues to accumulate. There are varying degrees of it. We know, and as some of you have learned with congestive heart failure, is we always want to weigh the patient. A 5% weight gain and it can be severe, can be causing a lot of trouble, could be causing edema or excess volume in the lungs with certain things like heart failure. So the best way to gauge if a person is having fluid volume excess is their weight gain. So we wanna get behind it. It's one of those things where we'd likely need to be weighing this patient daily to make sure we're getting rid of that excess fluid, or we need to do something about it. So with these disturbances, we want to know, so we know the fluid volume deficit and fluid volume excess, but now we need to know what the electrolyte imbalances are. And we know that it's an imbalance due to knowing that in our body we have certain levels of electrolytes. So we know that sodium should be 135 to 145, right? And we want our body to be in between those numbers. So then if we have less than 135, we're considered hyponatremia, and that just refers to sodium deficit in the extracellular fluid caused by loss of sodium or gain of water. So what happens when we drink too much water? We are diluting that sodium. We can also lose sodium through vomiting, diarrhea, sweating, dehydration. The decrease in sodium causes fluids to move by osmosis from that of lesser concentration in the extracellular fluid to the intracellular fluid space for greater concentration. The shift of fluids can lead to swelling of the cells, which may result in signs and symptoms such as hypotension, edema, cramps in the muscles, dry skin, weakness, sometimes confusion. We know that severe hyponatremia can be manifested in things like increased intracranial pressure, which signs and symptoms are lethargy, muscle twitching, and the most severe would be seizures or death. The opposite is hypernatremia. Hypernatremia is a serum sodium level of greater than 145 and caused by excess water loss. So excess water loss overall, or an overall excess of sodium. So fluid deprivation, lack of fluid consumption, diarrhea, and insensible water loss, such as burns, can lead to excess sodium. So with hypernatremia, fluids move from the cells because of the increased extracellular osmotic pressure, causing them to shrink and shrivel. This can cause severe central nervous system effects. So neurological impairment, restlessness, weakness, delusions, hallucinations. We can cause permanent brain damage, especially in children. Then there's hypokalemia and hyperkalemia, so that is potassium. So those are the potassium levels. We know that potassium should fall between 3.5 and 5, right? We want to stay in between that. That margin is very low. We want to know that, so we know that the functions of potassium they regulate a lot of our muscle. So if potassium regulates our muscles, then we need to make sure that we are keeping a good balance. So with hypokalemia, so we know that hypo is low and hyper is high. So hypokalemia is less than 3.5, and it is a common electrolyte abnormality. We lose potassium through vomiting, gastric suctioning, diarrhea, and we know those diuretics that are potassium depleting. So when it's less than 3.5, we know that the extracellular potassium levels fall. So then potassium moves from the cell, creating an intracellular potassium deficiency. Sodium and hydrogen ions are then retained by the cell to maintain isotonic fluids. The electrolyte shifts, can change the pH of our bodies. Typically, signs and symptoms of hypokalemia include muscle weakness, leg cramps, fatigue, paresthesia, and dysrhythmias. And usually the first thing that we feel are muscle aches. So muscles are generally the first sign that we are hypokalemic or a person is hypokalemic. Think of those marathon runners who run 13 or 26 miles, but they didn't have enough electrolytes for whatever reason. And they're on their like 15th mile of running, and they get what we call Charlie horses or leg cramps. That is ultimately that low potassium in our body causing our muscles to contract. Those Charlie horses that are very painful is what happens. And they can definitely continue running, but they're going to continue to lose potassium through their sweat, through their body. If they're diluting it with drinking lots of water, but not replacing that potassium. And the opposite is hyperkalemia or hyperkalemia, and that is excess potassium in the extracellular fluid. So that would be greater than 5. The biggest things, there are a lot of things that can cause this to happen, like renal failure. That's because their kidneys are not able to excrete it. NSAIDs, so non-steroidal anti-inflammatory drugs, are made with potassium. They have a potassium salt in it, so it can increase your potassium levels. Potassium-sparing diuretics. So we heard potassium depleting like Lasix. Now potassium-sparing diuretics don't actually secrete or excrete your potassium, so it just builds up. Although conditions are less frequent than hypokalemia, it can be much more dangerous. So nerve conduction in our muscles and the contractility are very affected by being hyperkalemic. So one can see a variety of cardiac irregularities from having high potassium, including cardiac arrest. So think about it, hyperkalemia. So potassium is the medication, one of the medications, because it's usually a cocktail of medications that they give prisoners that are going through their death sentence. So like if they are convicted and they have a death sentence, they do the date, and the lethal injection has a high component of potassium that will stop their heart. That's what it does. So hyperkalemia is severe enough to be lethal. This is why when we're giving, and you guys don't know this yet because you haven't learned the IV fluids and stuff, when we give potassium, it's never an IV push potassium because that will kill someone. All right, and so next we move on to calcium. So hypo and hypercalcemia. And we know hypo is less than 8.9, and then hyper is greater than 10.1. We know that calcium deficits can be from inadequate diet of calcium, impaired absorption, and it can be manifested in numbness, tingling of the fingers, feet, tetany, muscle cramps, and severely it can be seizures. As opposed to hypercalcemia, you'll have nausea, vomiting, constipation, bone pain, excess urination. Severe hypercalcemia is a medical emergency because it can cause cardiac arrest. Magnesium, so hypo and hypermagnesium. Magnesemia, I did not say that right. Hypomagnesemia or hypermagnesemia. That is magnesium, and we know the levels should be between 1.5 and 2.5. There are many ways magnesium can be lost in the body. So in hypo, you may see people who are showing muscle weakness, tremors. They can have seizures, heart blocks, and cardiac rhythm changes in their mental state, hyperactive deep tendon reflexes. So low magnesium can cause them to have their deep tendon reflexes really severe. And then they can have respiratory paralysis, as opposed to hypermagnesemia, so that's above 2.5, can manifest in nausea, vomiting, weakness, lethargy, and then loss of deep tendon reflexes. This can cause respiratory depression, coma, and cardiac arrest. Hypophosphatemia and hyperphosphatemia. It's not the bigger ones, but they can result in some severe problems. So we know the levels are 2.5 to 4.5. And then we know that hypo is less, so the body is getting rid of it too quickly or too fast and not replacing it. It can be a result of malnourished patients, patients who are in alcohol withdrawal. They may have absorption problems or the use of diuretics. So the manifestations would include weakness, confusion, seizure, irritability, and the biggest adverse effect would be a coma. The opposite would be hyper, so that means impaired kidney function. That can result in tetany, and tetany usually means, so yeah, tetany is like muscle spasms. You can, with hyperphosphatemia, you can have anorexia, not like the psychological disorder, but anorexia means without appetite. So lastly, we have chloride, and we have hypochloremia and hyperchloremia. Those are, I feel like they're a mouthful, but we want to be between the levels of 96 and 106. If you're hypochloremic, you would see signs and symptoms: hyperexcitability of the muscles, tetany, hyperactive deep tendon reflexes, weakness and muscle cramps. In the opposite, you'd have hyperchloremia, which is high or above 106. And signs and symptoms would include tachypnea, weakness, lethargy, cognitive ability, hypertension, decreased cardiac output, dysrhythmias, and coma. So, I mean, and these are just shortened versions of all of these manifestations. So just know that, know the difference between hyponatremia and hypernatremia. And I just noticed one is hypo and the other one is hypo here, but one should be hyper. Let me change that for you. But yeah, so it should be hypo and hyper in all of them. And just remember those, that hypo is low and hyper is high. And you'll be able to distinguish them. So just know, going through the nursing process of a fluid and electrolyte imbalance or balance, we want to know what we need to assess, because that's the first step, right? We assess, we collect data. If you look at table 4-3, it just gives you some information on some data collection that you would do. How does it pertain to that fluid and electrolyte imbalance? We know common things like diarrhea or vomiting can cause fluid and electrolyte imbalances. There's a lot of things that will cause these things. And so being able to assess to figure out which imbalance is happening is important. So the number one thing is knowing your lab values. So knowing that somebody who's going into kidney failure is likely to have a high potassium because they're not able to get rid of it. Things like that. These are things you can assess. Look at that table 40-3. We got skin turgor, tongue turgor, moisture of the oral cavities, skin appearance, facial appearance. Is there edema? What's the body temperature? We know that high body temperature is likely to be dehydration. What is the pulse doing? Respirations, blood pressure. The other things are your fluid intake and output. We want that balance, so we want to know. So if somebody's presenting to a hospital with some sort of fluid and electrolyte imbalance, we definitely want to keep a good record of their fluid intake and output. Very, very important, daily weights, right? We talk about this with congestive heart failure, but we know with congestive heart failure, they tend to have fluid overload, right? And we tell them to weigh themselves. So a daily weight is very important with a fluid and electrolyte imbalance. The laboratory studies, so, and you guys will learn a little bit more about this, but a complete blood count. So we want to see what the red blood cells are doing. As you can see, an increased hematocrit value can be found in severe fluid volume deficit and shock. Decreased hematocrit level would be acute massive blood loss or some sort of hemolytic reaction. Increased levels of hemoglobin would be found in hemoconcentration, as opposed to a decreased level would be anemia, severe hemorrhage. So being able to know these things will help you figure out what assessments you need to do. So once you have your assessment, you can proceed to the problem. So the problem or your nursing diagnoses. You can look for, if it's a fluid imbalance, it could be excess fluid volume or deficient fluid volume. In addition, you have the risk for. So risk for deficient fluid volume is one. More towards the electrolyte, you can have impaired oral mucosa membrane, risk for impaired skin integrity, ineffective breathing patterns. So depending on the electrolyte that's being affected, we know some of these electrolytes can cause heart problems, respiratory problems. So depending on the fluid and electrolyte imbalance is how you're going to pick your nursing diagnosis. Thereafter, you're going to validate. Look back at your assessment data. Does it make sense, right? So, for example, if you have a patient with deficient fluid volume and they haven't had any weight loss, right? They haven't, but they are showing signs of dehydration. They still weigh the same, they have signs of dehydration, and they have an increased abdominal, like their abdomen has increased in size. Maybe third spacing is occurring. So technically they're deficient in fluid volume, but they're not presenting in the way we would think because they're having that third space shifting, but they're deficient in fluid volume because that fluid is not in the right space. So once you've confirmed your problem, you start outcome identification, right? ADPI continues. So you want goals. Goals, should derive from your actual and potential imbalances. You want to make a goal that is, what are the rules in making goals? So we want it to be attainable. We want it to have a time constraint. Examples would be maintain an approximate balance between fluid intake and output. Maintain a specific urine gravity. And always we want our patients to be able to practice self-care, right? To promote their own fluid and electrolyte balance. How do we implement? So what do we do to correct what's going on? Well, we know that a lot of fluid and electrolyte imbalances have a lot to do with dietary modification. So someone who's taking a potassium sparing diuretic, well, we have to teach them. If their favorite fruit is bananas and they love bananas and they eat 3 a day, well, we got to teach them differently because they are going to be in trouble if they continue. Modifications of fluid intake, whether it's to increase it or decrease it, depending on what's going on. Medication administration. So this is a big thing. So we might medicate our patients. If they're hypokalemic, we are going to give potassium. If they're hyperkalemic and they are also on a potassium sparing medication, then we won't give it. You guys won't learn this until next semester, but IV therapy is quite important in fluid and electrolyte imbalances. And the biggest thing is teaching. It is in caps because I'm not screaming at you, but teaching is one of the biggest things. And you start doing that as soon as you encounter your patients. What do we evaluate? So, has there been progress? Is the patient drinking or eating accordingly? Are there the patient's intake and output balance? Does it make sense? Or is it severely imbalanced? Is the patient back to baseline? Are they able to go back to their baseline and practice their own care? So as with any evaluations, you know that with a plan of care, you will implement it, and ultimately you want to complete or terminate your care plan, but only until your patient and family are able to independently promote their wellness. All right, so we're down to the complete blood count now. So we want to identify the total number of blood cells. So leukocytes, erythrocytes, and platelets. So what are leukocytes? Leukocytes are white blood cells. What are erythrocytes? Erythrocytes are red blood cells. And platelets. What is a platelet? Platelet is what helps us clot. Hemoglobin and hematocrit are types of cells that that heme is oxygen carrying. So they both carry oxygen in some way. So what are the normal levels of a white blood cell, a red blood cell, a hemoglobin, and hematocrit, a platelet? So you want to look those up. Those are in your book. You will need to know those so that you can make an appropriate judgment on your test questions. And then you need to know what they do. And then I just have a brief slide about those. So white blood cells, they fight infection. And within the white blood cell categories, we have neutrophils, monocytes, eosinophils, basophils, all those other ones. They all have to do with immunity, fighting infection, things like that. Plasma cells. So plasma cells secrete immunoglobulin. Red blood cells, or what we call erythrocytes, they carry hemoglobin. So hemoglobin is to provide oxygen to the tissue, while the other, it's where that oxygen exchange occurs. Platelets are coagulation cells. Basically is what we want so that if we cut ourselves, we use platelets to clot. That's how we stop our bleeding. I just want you guys to know their basic function and what occurs if a white blood cell count is too high or too low. What happens when a red blood cell count is too high or too low, and what happens with platelets when it's too high or too low. And then as part of your red blood cells, because red blood cells are hemoglobin and hematocrit, what does it mean if your H and H, hemoglobin and hematocrit, are too low? What is going on? You can determine a low H and H, and the patient might have severe blood loss, or they might be anemic. So just know those very basics, and you will see them in your MedSearch textbook. Well, guys, I've made it to the end of my lecture. I will see you guys on Tuesday.